Okay, all right. So today we're going to present the second edition of the Echo Cases Potpourri. The first one that I did was probably about a year ago. Actually, it was May of 23. But this is the this is the contrast edition. So they're all contrast cases. You guys know I like contrast, right? So okay.
No.
We're one of the highest user in Ontario.
I suspect it's the highest user in Canada, actually.
That's the epic words. Grace.
Okay, all right. So this is very case-based. So, but hopefully we can kind of discuss the cases and talk about optimization and so how to apply the use of ultrasound enhancing agents or contrast within your lab for kind of standard applications and some sort of outside the box application. So you'll see some cases in the lab. I pulled a case that was like very old. You'll see actually. But it's a classic. It's a classic. Okay. All right. So the first case is an 80-year-old woman who has a history of a prior anterior myocardial infarction and ischemic cardiomyopathy, and it's a standard assessed LV, systolic function, LVF, ruled out LV thrombus. It's a pretty short case. It's just to kind of get us warmed up. So it's a little dark. Could somebody put the lights on off in the front? Okay, I don't get don't sure if we need it that dark, but that's okay. All right. So what do we see here? Last one of the stenographers.
4 and 2 chamber.
Yeah, so it's apical 4, apical 2 chamber view. Beautiful. Okay. So and what else do you see, Grace?
The apex is apathetic.
Yeah, no, and it's an apical aneurysm, right? It's quite a large apical aneurysm. Remember, an aneurysm is a shape distortion or shape change that is present during systole and diastole. So it's not just during systole; it's also during diastole as well. And many times, aneurysms are akinetic or dyskinetic. So, you see any thrombus?
Very suspicious. Not highly suspicious.
Yeah. Okay. All right. Why would you say it's highly suspicious?
Well, first of all, it's aneurysmal.
Yeah, so the substrate is there for a thrombus.
Some shadow.
Yeah, so you can see my pointer shows up here. So yeah, you can see this question is that a thrombus there? Is that artifact? And we certainly do see a lot of artifacts at the LV apex on 2D echocardiography, and that's one of the ways that ultrasound enhancing agents can help us discern whether or not there's a thrombus there or not. Okay, so we of course we give contrast, of course, because okay. So right. So here's a couple of zoom views, and perhaps what do you see here, Grace?
Laminated. That's a laminated.
Yeah, so this is a classic laminated apical thrombus, which I think without contrast we wouldn't be able to appreciate it. So a couple of key learning points here is that, and it's something that we ask stenographers to do on a regular basis, is that we acquire the standard apical views, focusing mainly on the left ventricle, focuses at the annulus of the mitral valve. We want to get good homogeneous pacification of contrast within the left ventricular cavity. We want to see the endocardial border as well. And then on top of that, we ask them to do zoomed views, especially if there's apical abnormalities that they're looking at. So ideally about a third, maybe up to half the left ventricle. And with that, you're allowed to give more contrast or more ultrasound enhancing agents to really fully opacify that LV apex. And if there's an aneurysm, we know that there's stasis of blood at the apex. And sometimes the apical aneurysm is difficult to fill with the ultrasound enhancing agents. So you get all that swirling that you see. So if you see that, then you have to really give more agent. You really have to, you also always have to give enough contrast agent to cause attenuation at the base. But with the zoom views, you don't care about the base, and you want to focus at the apex. And here the focus is at the apex. And as Grace mentioned, you can see there's a laminated apical thrombus. It's quite broad, actually. You can see here in the 4-chamber, the 3-chamber view. And you also want to angle a little bit here. So you can see we're angling a little bit here in the 4-chamber view. So here you can see it's a little bit more thicker here on the apical lateral aspect. And how do you differentiate this from myocardium? is always a question, because a lot of times we're not sure whether or not what we're seeing is actually just delineation of the endocardium versus a layered apical thrombus, and you can see here it's quite smooth there. So what I like to look for, I like to look for little ridges or indentations at the edges between the true endocardium and where the thrombus starts. Usually thrombus tends to be quite dark on contrast-specific imaging, and the myocardium, even with an infarcted segment, usually there's some signal to that. And ideally what you'd like to see is you'd like to see the dark thrombus, and you'd like to see a little bit of the thinned myocardium outside of that. It's almost akin to how we look for thrombus on MRI with delayed enhancement. But with delayed enhancement for MRI, it's the opposite. The thrombus is bright because it's enhanced, and the myocardium is dark. Here the thrombus is dark and the myocardium is a little bright. So you can see it here as well. So you can see how black this is. So usually the myocardium is usually not this dark. Usually there is some signal. But depending on the machine settings, etc., it can be a little bit difficult to differentiate. Protuberant thrombus is easy to see with contrast. It's a big filling defect that does not pacify in the setting of a substrate like an apical aneurysm or a Walker-Schadt. So these are challenging to differentiate. Okay, so that was the warm-up case. All right, so case number 2. So this one is a 66-year-old man, prior bypass surgery for 3-vessel coronary disease. And that was done after a non-SC segment elevation of myocardial infarction and usual, LVF without LV thrombus. So, okay, all right. So maybe I'll ask one of the cardiology residents, somebody to see here. Anybody want to take a go at this? Michelle? Yeah.
So basically,
Thank you for stepping up. Might have to talk a little bit louder. Yeah, go ahead.
on the left, we have the 2-chamber view, a 3-chamber view in the middle, and then another 2-chamber view.
Yeah, 4-chamber. Yeah, exactly. Yeah.
So just looking at each image separately, the 2-chamber view, the anterior wall seems to be fine. The inferior wall is cytokinetic. There's something there that the apex, I'm not sure what it is, but it's like, it has it's just not, when it's not moving in with contraction, it's just kind of the movement is not keeping the muscle. So I wonder if there's possibly a thrombus there or something else.
Yeah. Yeah, so no, I agree. Actually, it's probably the classic global with regional variability. You can see the inferior wall is probably more affected in the 2-chamber view, maybe the infralateral, maybe the infraseptum. So it's, we know the patient has coronary disease, etc. And as you said, there's this echogenic structure at the apex, and it's an area where the wall is not contracting fully normally as well. So the question is this an LV thrombus?
It's actually more prominent in the 4-chamber view.
It is, yeah, exactly. No. And I think there was initial thought that this was a thrombus, actually. So, all right. So of course we give contrast. So you can see here, actually, there's a filling defect at the apex here. Probably a zoomed apical 4. This is just another apical 4 that's a bit different in terms of probably the angle. You could see a little bit less of the RV, so maybe it's a little bit tilted over to the apical 2-chamber view. So what do you think, Michelle?
How does this use for a thrombus?
Yeah. Okay. So I agree. So it's a non-enhancing echogenic structure that's somewhat circular. It's at the LV apex. What's unusual if this is a thrombus? What's the unusual part?
It's not sitting somewhere.
Yeah, it's not. It doesn't look to be attached to the wall, right? It kind of. So could it be a free-floating thrombus at the apex? Very unusual.
It could also be. I don't know. I'm not sure, to be honest with you, but that's another thought that I have. It's just a normal cardiac structure that we're seeing.
Yeah. So could this?
Visual appearance that we discussed earlier.
Yeah. So could this be something else? Like, could this be like a muscle bundle? Pap muscle would be a bit unusual in this current location, but and actually this turned out to be a muscle bundle, and the way we figured that out is just by panning through, and so you can see actually this is apical 4 on the left, apical 3 on the right, And this is where X-plane imaging. If you have a 3D transthoracic probe and you put the X-plane cursor right down the middle of the apical floor, you probably would get a orthogonal view where you can see this muscle bundle. This quite thick muscle bundle that you can see here that running. So here, this is just an on-fast view of that muscle bundle. That's why it seems that it's kind of floating in the middle of nowhere. And actually, it was actually very difficult to appreciate this aspect here without the use of contrast for LVO classification. So this was a muscle bundle and not a thrombus. As you can imagine, it makes a big difference, right? If there's a thrombus identified, patient goes on an anticoagulation, and has follow-up, etc. So it's something useful to distinguish.
Was it confirmed on CT or MRI?
No.
Or other modalities?
No.
But this is good enough.
I think this is good enough. I think a lot of times we'll defer to CT, but echo has to step up and make the call, right? So, and contrast allows us to do that. So, okay, all right, we're moving along. Case 3. So, 65-year-old man, history of a end-STEMI non-S-segment elevation myocardial function. Once again, assess LV slot function, wall motion anomalies, rule out LV thrombus. So this is what I refer to as a who was here in 2004 other than me and Dr. Chow? Who was here? Anybody? Any other sonographers? No. Okay. You guys recognize what system is this? What system is this?
What is that? VIGMED.
It's the VIGMED. Yes, this is the precursor of GE. So VIGMED was a Norwegian company that. It was the first digital ecosystem. So it actually was, to Dr. Chow's delight, it was Mac based. So he essentially had a Mac on an echo machine. Like literally, it was a Mac. And we read off Macs too. I don't know, you guys were there. So we were the first, St. Mike's was the first digital echo lab in the country. And that was because of Dr. Hutchison, who was the echo lab director at the time. So we had the VIGMED systems. They were like Volvos. They were like boxes, back on top. Do you remember those? Yeah. So these were, and that's why the classic V. I think I've said this on these rounds for a good book. Nobody really asked. So why it's a G system? Why is there a V there? What does that stand for? So it's a holdover from VIGMED. And actually, when I was a fellow in Virginia, we used the VIGMED systems for contrast as well, for when we do some of the initial applications. So this is circa 2004. And if you thought the images were bad now, look at this is like a super TDS. So apical 4 on the left, and apical 3 on the right. You get the sense overall LVF looks normal, right? Maybe a little bit hyperdynamic. Okay, so we gave contrast. Okay, so the images are fuzzy. Please forgive me, but do we see any abnormalities here? I'm going to show you 3 contrast zoom views. I think this is an apical 2 or an apical 3. It's not the 4. Can anybody see any abnormalities? This is wide open. Anybody who wants to jump in.
Contrast is going to the myocardium there, like
yeah. So there's something here, like a little tongue. Okay, so I'm going to show you 3 images, and then you can tell me what you think it is.
This patient was post-MI, right?
Yeah. So that's a 3-chamber view. You can see if you're an expert contrast user when you can tell the view without any of the labels. Because just from the experienced sonographer and echocardiographer, you can tell just based on the shape of the ventricle whether or not it's a 4 2, right? Am I right? Yeah. There's a 3. Okay. Yeah, you can see a little bit of the LVOT over here.
But still better put the label on.
Yeah, that's probably true.
Of everybody.
No more labels.
No, I don't need labels. Okay.
The label is free. Use them wisely.
Okay. Okay, and then really a zoom view here. Okay, so what's this? What is this?
A tongue.
See right here?
Tongue. Okay. Echo tongue. Okay. So what's it? Well, okay. So what's the differential?
So I guess like
Yeah.
perforation post.
Yeah. So pseudoaneurysm. Okay. Pseudoaneurysm. Of course, if you consider pseudoaneurysm, then you could have to consider true aneurysm. Okay. And is it typical for a pseudoaneurysm? Yeah. What's it typical about it, Jamie?
It's just like it's like I haven't seen a lot of them, but it looks like almost too defined.
Yeah,
like, in a specific
yeah,
spot.
Yeah, you can imagine this is like the tiniest transmural
Yeah.
that you'll ever see.
Yeah.
Like literally, it's like a fraction of the myocardium. Yeah, so that brings in the other differential that this.
Could be a cleft. But
Yeah, well, the cleft is not the right. It's not the cleft is the right kind of concept, but there's another term that's used more commonly to describe this. It's a diverticulum. So this is a diverticulum. Yeah. So, all right. So that's a diverticulum, and actually, I don't want to downplay echocardiography, but this is the LV angiogram. So I have to admit, the LV angiogram shows it better than the contrast echo. Although that's like big bet, back in 2004. In today's world, probably not. So the flip side is that we actually don't do LV angiograms a lot, and the flip side is that how often do you see an LV angiogram done with a pigtail catheter versus the right coronary catheter? It's like 90% right coronary catheter, 10% pigtail catheter.
That's right.
And with the right coronary catheter, you don't get good opacification of the left ventricle. You really don't. So this is actually with a pigtail catheter. It's like directly into the apex, and you can see the diverticulum here in the infralateral inferior wall here. And on top of that, you can actually see it contract. You see how it contracts with so pseudoaneurysms don't contract, right? So the focal aspect of it, etc. So this is an outpouching. That's a LV diverticulum. Okay, so an LV diverticulum is thought to be a congenital abnormality. It's estimated in about 0.4% of autopsies, 0.26% of LV angiograms. Although, as I said, we're not doing as many LV angiograms as we used to. It's actually difficult. You need really good image quality for echocardiography to see them, but you can see them much better with contrast. But you have to be looking for them, or you have to be paying attention when you do the study. The anterior and the inferior walls tend to be the typical locations. It's important to distinguish, as Jamie mentioned, distinguish this from infarct-related complications, both pseudoaneurysms and true aneurysms. And then contractility, I think, is a key component. A lot of these are muscular diverticulum or diverticula that contract as well. Every now and then we'll see some that don't contract as well, but diverticula technically they have all layers of the muscle, although maybe thinner than usual. Okay, so that's the diverticulum.
How does like a crypt differ from a diverticulum?
Yeah, so the way I look at it is that first of all, crypts or clefts, they tend to usually occur in the setting of hypertrophic cardiomyopathy. So there's a lot more muscle to deal with. So, and I was looking at it, I think it's, there's no hard definition per se, but consensus or expert opinion are that crypts or clefts usually have at least 50% depth into the myocardium. Where diverticulum, I think, actually are more likely to extend outside of the myocardium. They kind of bulge out, and you can tell from the LV angiogram, it really does look like it's extending well beyond, because the walls are not that thick. So I think that's really the one kind of differentiators.
Thank you.
It's kind of the setting and the depth of the thickness. Yeah. Okay. Case 4. Had 6 cases. Okay. Try not to go too fast. Okay, so trying to check if I think I've made the points that need to make, at least from a technical side. Before I switch gears, although no, this one's a little bit related. Any questions so far over contrast settings? Okay, all right. So this is a 16-year-old man with mild. This is actually patient Dr. Conley. Mild atypical chest discomfort localized to the left chest. Non-exertional, but has some short breath on exertion going upstairs. Has some risk factors, has high cholesterol. I was going to put this ECG. This ECG had T-wave inversions in the inferior and the anterolateral leads. Not very deep, probably about 5 millimeters T-wave inversions. I was going to put it up, sorry. You'll have to kind of visualize it. It's not normal. Okay, so this is a stress echo. So the patient was sent for a stress echo. This is a stress echo that I read actually. So so I asked one of the fellows to stick handle this one. There are only 3 fellows. So well, there's 4. I'm not sure if you see this yet. No, he's clipping today probably. Okay, so I'm going to show you the apical views for the stress echo. Which of the fellows wants to take this?
Don't fight.
I would say it's not subtle. It's not subtle, but it's not straightforward either. How about that? Is that cryptic enough? Talking about crypts, yeah.
I can go.
Okay, Mike.
So in the rest images, already the LV looks hyperdynamic.
Yep.
I'd want to see a little bit more, but I'm suspicious that the apex, like the myocardium, doesn't really taper towards the apex. So
Okay, all right.
could the patient with this ECG have like a history of hypertrophic cardiomyopathy?
Yeah, so you're thinking, well, could this be apical HCM? Okay.
Yeah.
Yeah, okay.
And
I
then
have to admit, the T-wave version were pretty nondescript.
okay,
Yeah.
fair enough.
But still, the ECG is not the be-all and end-all for apical HCM, right? So,
No. And then what's striking is that at the peak images, it looks like there's an apical aneurysm.
yeah, so over here. Everyone see that?
And otherwise, the LV becomes more dynamic with stress, with the exception of the apex
Yeah, okay.
prismal. And I'm not sure, maybe that's just kind of the angle that we're catching it in this. And so having some some more rest images and making sure that is it actually they're at rest.
Yeah, so we actually only see the abnormality at peak stress. We don't see the other views, right?
Yeah.
Keep that in mind because we're going to look at the apical views. Here's the apical 2.
Yeah, so we see it now. So again, at rest we don't see it, but at the intermediate and peak, we again see this apical aneurysm. And then in the recovery images, we see it. And it looks actually smaller in the recovery images compared to the peak and intermediate.
Okay. All right. Yeah. So it's kind of inconsistent here. It's there at the 2 stress images, but wait a minute, it's there in recovery. So did it appear and that was persistent? Was it there at the very beginning? Right?
I'm not sure.
Here's the 3.
They do look for sure. Yeah. So the 3s, I don't appreciate it.
Yeah, you don't see it at all in the 3-chamber view, right? So
A little bit in the peak. Yeah, maybe a little bit in the peak.
Yeah.
But they're all kind of.
Actually, this is 2022. I can tell you the sonographer didn't see anything, and the fellow who pre-read the study didn't see anything. Global study. No, but it's a very subtle abnormality, right? And it was kind of a low pretest problem.
And it's probably coming in and out with
The patient went like
right immune stuff. Nice.
okay. So all right. So So what's the most likely diagnosis? Is it LAD ischemia? I didn't see any resting images. He saw it there. Is it a par LAD infarction with apical aneurysm? Or is it apical? We talked about diverticulum. Is this an apical diverticulum, right? And then you could add to that your thought about, is this apical HCM with apical aneurysm? That's the other potential differential, right? So, it's kind of difficult. I don't think you could say for sure based on these images.
Yeah, if it was LAD infarction with apical aneurysm, like the rest of the apex moves very well. The anterior wall moves normally. It's really just like a focal.
It's pretty focal, yeah.
Focal area of infarction and aneurysm.
But is it focal enough to call an apical diverticulum? Now, the other thing is not contractile, right?
No.
Okay, all right. So here's the rest echo after the stress echo. Apical 4. Yeah?
Yeah.
It looks bigger now, right? You can certainly see it better. And, I think we never saw it on the resting images in stress echo. It goes to your point about, if you just go back actually, and you look at the images, and look at the apical 4.
Yeah.
It doesn't really look that foreshortened, right? So it just tells you sometimes it's difficult for us to catch the true apex, and sometimes you have to really scan through a little bit. Okay, so it's a little bit foreshortened, but it's pretty triangular. We always talk about the apex. A lot of times we look at normal studies and the apex looks somewhat rounded, right? We know that the apex normally is not round. It's actually pointy. It actually tapers off. So we echo foreshortens a lot. So to scan through, that's the advantage of 3D echo when you're trying to get the true apex. And that's also the strength of MRI to get the true apex. So sometimes it's difficult for us to get the true apex. So, but if we know what we're looking for and we use contrast, then it's easier for us. So look how long this is a very long left ventricle, right? So this is a very focal apical abnormality. And here's a zoom view. Like, look at that. It's a focal apical aneurysm. Right? Etiology unclear. I wouldn't call this a diverticulum. It's too big. It's not contractile. So now whether or not this is a focal apical aneurysm because of coronary disease or ischemia or infarction or an apical aneurysm as a result of burnt out apical HCM, I don't think we can say for sure. Having said that, this seems a bit. It could be either one. What can I say?
Yeah.
We've seen both. Anyway, so the patient had both an angiogram and a CMR. These are the tests that we would normally use. This is in our wheelhouse to look at. So the CMR MRI scans showed a focal aneurysm of the true apex, transmural late gadolinium enhancement, so full transmural enhancement, keeping with chronic infarction in distal LA territory. No other findings that would suggest apical cardiomyopathy. And patient does have coronary disease, but not of the LAD. So had focal 80% OM2, 30% mid LAD, 56% diagonal, minor irregularities in the RC. Yeah.
For sure.
Could it be embolic? That's also a possibility, I guess.
Yeah. For sure we saw the LAD wrap around the apex in this.
I can't remember the exact anatomy, but yeah. But don't forget, most LADs do wrap around the apex. The question is how much around the apex it wraps, right?
Yeah.
So, okay. All right. Okay. Then to finish up with a couple of valve cases.
So
yes.
to kind of wrap up that case, so what do you think it's actually maybe embolic ischemic? That whole thing? I'm just curious.
Yeah, so I don't think we can say for sure. Having said that, I don't think the treatment would differ too much. Patient has some underlying atherosclerosis, so managed for aggressive secondary prevention. Overall LVF is normal. There's no indications for revascularization. The MRI didn't suggest any other type of unusual cardiomyopathies that need to be further investigated. So it's really just clinical follow-up. That's kind of the practical aspects of it. If you don't know for sure, then the practical aspect is you're not going to really change the management. I actually when I read the stress echo, I thought it was LAD infarction. It's just very focal. It's at the very distal level. There wasn't a residual hypertrophy that I would have had my hat on for apical HCM with infarction. And the other thing is that I can't say for sure, but my sense is that the apical HCMs that have apical infarction, they have a lot of apical hypertrophy. They don't just have subtle, mild apical hypertrophy, right? Is that really thick hypertrophied apex that infarcts because of the hypertrophied myocardium, and despite normal blood supply gets ischemic and necrotic. That's my. I don't know if I can't give you any references to say that, but that's the way I look at it. Okay, so we've done lots of contrast examples for LV opacification, looking at apical abnormalities, aneurysms, diverticulum, LV muscle bundles. So now a couple of outside the box applications of contrast to help delineate abnormalities that we see on echocardiography. So here's a 56-year-old woman post bioprosthetic aortic valve replacement and a VSD patch repair for complicated infective endocarditis. What do we see here? We will ask. Shall I go back to the stenographers? Yeah. Okay, I'll open it up. Anybody want to?
Personal long access, mitral valve, looks like it too. And then I wonder if there's something on the anterior aortic valve.
Yeah. Oh, you mean over here?
Yeah.
Yeah, well, it's a brand new bioprosthetic valve. It's a little bit bright. This is probably artifact here.
And the wall, like the septum looks a little bit sigmoid, and maybe there's some like hypertrophy that you see in the ventricle.
Yeah, so maybe out here. There's a bit of tapering here when it gets to the annulus. So what's this, Jamie?
So that's the RV.
So that's the RV here, RVOT.
Yeah.
There's a structure here that's anterior to the root and anterior to the basal septum. Do you see that here?
Yeah.
It's bigger.
Yeah, so yeah, it does expand a little bit during systole. I'll go back so you can see that. So there's this
Was that the patch up here?
echolucency. The patch appears here. There's echolucency here that's anterior, that's abnormal. And it does expand a little bit during systole. Sometimes that could be a bit of motion, you never know. So here it is on the short axis. Yeah, so you can see here it's a bit anterior and a bit lateral to the annulus of the
It
aortic.
kind of looks like it's like opening out for the aortic valve, right?
Yeah, it looks like a cavity. And is there flow within the cavity? You can see a bit of pulmonic valve, pulmonic regurgitation.
I don't see much flow inside.
Yeah, it doesn't, nothing definitive, right? Yeah, so the question is whether or not, so this is it's an old abscess cavity that got drained. The question is whether or not there's any communication of this cavity with the blood pool. And that's one of the things that we use contrast for, at least in our lab, I would say relatively routinely. It's something you should think about. If you see a structure that you're not sure what it's connected to, is it connected to one of the chambers? Is it connected to the blood pool? What's the origin of that structure? Then if you give contrast, the bubbles will go everywhere blood flows. So it's one of the things that once you inject intravenously, and you can put the probe anywhere in the body, and if you see bubbles there, that's attached to the blood. So that's why it's useful to detect, for example, we talked about that case of at M&M rounds. It's useful to there's some nuances behind it, but it's useful to look at whether or not there's a leak from the chambers of the heart into the pericardial space by using ultrasound contrast. There are a number of studies have done that. We've done that here as well. But there's some nuances behind that, and the same here when you're not sure if this is attached to any of the cavity, any of the chambers of the heart. Plus, the other differentiator is which chamber is attached to. So in order to do that, when we give contrast, we have to do a first pass contrast where we start imaging. It's almost like saline contrast. We start imaging, and then we inject contrast, and then we follow the contrast through all the chambers and see where this chamber fills, if it does fill or not, in relationship to the chambers that are filling. So then you can have an idea of where the connection is coming from, which makes a difference in terms of if you had to tell a surgeon, listen, there's a leak, where is the leak coming from? So based on this, do you think there's a bit of systolic expansion? So maybe it's a leak, there's motion. You don't see any color Doppler, so we're not sure if there's a leak. So do you think there's a leak? You don't know. Okay. Hard to tell. So here's the first pass. And I'll play it a few times. So remember, you injected intravenously. It goes in the RV, LV.
Yeah.
Oh. Yeah, exactly. At least this is why it's like it's the new eye. It's like, oh my god. Okay, let's look at that again. And then now you can pay attention to the timing. We don't want to pacify. So this cavity is definitely connected to the blood. Right? Sorry, it's a very long loop. Gamma. And at the very beginning, there's attenuation of the ultron beam, and then it kind of, as concentration falls, yeah. So what do you think the connection is? So this tests timing. This is a very important skill of a sonographer and echocardiographer is the temporal, because it's all about moving. We always assess moving structures, right? So the temporal aspects become important.
It's after the aorta.
Yeah, exactly. So it's definitely after the LV, and it's after the aortic root's opacified, right? So the leak is really at the annulus, but connection is to the root. here it is again. Yeah, and you can almost see a bit of spurt as well going into it as completely filled. So it's a big cavity leak. Okay, so this is a residual patch leak. Anyways, the patient was stable. Didn't go back to the OR, just managed conservatively. So it was a very complicated surgery. Like, how I was seeing was that the valve was pretty much falling apart. There was a big abscess cavity. There was a VSD from the effective endocarditis. Patient was doing well. There's no way the surgeon was going to go back in. It's like, yeah, it's like, yeah. It's like, why did you even do the study? I don't want to know this. Okay. This is it. Last case, kind of similar but different. Well, kind of. So, 69-year-old man, post valve sparing root replacement. If you like the last case, you'll really like this case. So, I'm not sure if I showed the fellows this case before. Maybe not. Okay. All right. So, did I ever show the fellows this case? No. Okay. Well, I'll ask the fellows to tackle this one. This is a bit of an unusual case, but it's not impossible. It's just okay, Rudy. You can do it. And you could have your friends chip in. That's okay. She'll help you out. I know they support you.
Doing a personal long.
And this room, it's a valve sparing root.
Valve sparing root. So there should be a native aortic valve, and we should be seeing maybe the beginning of the graft of the ascending aorta. The root, I guess, particularly in this case, if you're looking immediately post-op, you're looking for any signs of any residual or any leak around the graft, or any collection around the graft.
Yeah, and you want to look for valve function. You want to make sure that the valve isn't disrupted, residual aortic regurgitation.
Yeah.
Okay.
And then looking at the zoomed in view on the right, thinking, and specifically the aortic valve, you can kind of see the leaflets opening there.
Yeah, and they open pretty well.
They open pretty well. You get a sense of, in terms of linear density of the graft. You kind of see the graft there. Immediately above it looks like the RB. Immediately underneath it looks like left atrium. I don't see any collection or anything untoward.
Yeah. Okay. Anything else you see? Anything else that you kind of? Oh, what's that? Or, not sure what that is. Or is that artifact? Or is that?
I mean, there is right above sort of the superior graft edge there in the RVOT. I see something linear as well. That's kind of at a different angle.
Yeah. So maybe here.
Yeah. Hold on. There's two arrows here. Yes, the black.
So keep an eye on that. Color. As usual, this is a GE color. Yeah. And a touch over gain too, right? It's a lot of it's good color.
It's useful to actually turn down the background gain in this case when you have the color on.
Just looking at this, starting, we'll start at the bottom of the microvalve, not really seeing any sense of microvegetation. Again, the sense that there might be a jet of aortic insufficiency there.
Yeah. Okay. Yeah. Tracer mild. Yeah.
Tracer mild.
Yeah.
And then looking in the RVOT in Sicily, there is certainly some color there. It's very splashy. I don't know whether that's flow going out of the RVOT or is there a connection to the LV and RV there. So
okay. So this chest test is if you can identify the first thing is identify the view and what you're looking at.
So looking at when we're at the peritoneal short axis.
Yeah, exactly.
Right?
At the aortic valve level, right?
At the aortic valve level.
We're at the base.
The aortic valve looks as expected, it's opening well. Then in the RV, there is this kind of rounded, you see the rounded linear structure there that seems to also respect, the color flow seems to respect it. It's like going around it there. Which is huge.
Yes, definitely. Very unusual. And what's the image on the right?
So that's CW. We're looking at flow acceleration around that structure. Velocity there is 4 meters per second, which is fast. Like I'm thinking about, that might be blood coming from left ventricular contraction, or if there's some severely hypertrophied RV, then maybe RV. But I'm thinking now about, okay, why is there a connection between what I'd expect LV blood flow during systole, and then what I'm seeing in the RV.
Yeah, so
RVOT there.
yeah, so so what are they sampling? What's the sonographer sampling? No, you can't see the thumbnail. The thumbnail is actually difficult to see up here. So
But that flow acceleration sort of
yeah, the
lateral
acceleration.
side.
Yeah, so this is actually a gradient across the RVOT caused by this structure. Question is what's that structure? Okay. Yeah, so what's the abnormality? Okay.
Something like flopping inside of the tube.
Oh, let me see. Sorry, Michelle, flopping? What's
Yeah,
flopping?
there's something that's like kind of sitting inside this structure. I don't know what to make of it.
Yeah,
Craft be somehow compressed in the RVOT.
Yeah.
yeah, there's something. See here, and so whatever the structure is projecting into the RVOT and causing obstruction. So what's the size about?
It's okay.
All right. Okay. So
Contrast.
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 Good answer. That's always the correct answer of these ones.
Contrast.
What the heck? What the heck? So there's no contrast opacification, right? There's no connection of this structure to the blood pool. Okay, that's we do it on multiple views. A nice big first pass. And here's a
thing.
zoom through here. Not bad, eh? What the heck? What did this surgeon do? Could have left this. Call CPSO. All right, it'll all come clear in a second.
Don't call CPSO.
This is pre-op.
Oh.
Ah.
What do we see here?
It's the aneurysm beside the
Yeah, this is a ginormous aneurysm of the right coronary sinus of Valsalva.
Wow.
Here's the short axis.
Wow.
That's great.
That's crazy. Yeah, that's crazy. And look at the flow acceleration in the RVOT. So that was already compressing the RVOT, causing RVOT obstruction, just from this, very unusual focal sinus of Valsalva aneurysm with the right coronary sinus.
Which is wild.
Dr. Peterson, as you can imagine,
Why is there not as much flow inside the aneurysm during
test world.
diastole? It's just so low flow.
yeah, it's colored Doppler. Okay. Yeah, so it was a valve sparing root repair with pericardial patch exclusion. So what you saw there was just residual aneurysm that was excluded. And then reconstruction of the root with aortic valvuloplasty plication, repair of the right coronary cusp and cavity times 2, and no patch deep was identified postoperatively. All right, here's the last cool thing about this is here's the transthoracic echo like 3 months later.
Oh, no way.
What, it just shrunk?
Just resolved.
And that's
Yeah. And actually, Dr. Edwards read the study, and the only time I've ever seen this term used on a report, he says the previously reported myself as involuted.
Is that expected?
Involuted. I actually would not expect it, but I guess this is what happens. Actually, and Dr. Peter says, that'll just go away. Don't worry. Oh yeah, that's don't worry about
Yes,
that.
they excluded it from blood flow, right? So eventually
It just got absorbed. It's crazy, right? Who would have thought, right?
Body is like, no, it doesn't belong here.
The human body is amazing. What can I say?
Thank you for sharing these very interesting, exciting cases. The wonderful and worst echo nightmares at the Canadian Cardiovascular Congress. So, and also in our CSE meeting coming up in April. So, thank you once again for sharing these wonderful, wonderful cases from our archive.